Bombay Spine Society's residents and fellows training program. So today's topic is osteoporotic spine fracture. Um, we have with us Dr. Rakesh Dhake, Dr. Shiblee Siddiqui, and our affiliate member Dr. Deepak Joshi from Chandigarh. He'll be giving the lectures on different aspects of the osteoporotic spine fracture, and we have senior faculty Dr. Harshad Argekar, who will be here to guide us for any confusion we'll be having. So I would like to just thank our sponsor at the outset only, and that's Intas Aquila, the manufacturer of Gabapin NT. They have been there with us since the very beginning, Gabapin NT and Gabapin, and they have been sponsoring our program since the beginning. So we would just like to thank them for their logistic support. And without much further ado, may I request Dr. Rakesh Dhake to please start his talk on the pathophysiology, diagnosis, and classification of osteoporosis in spine. Rakesh, over to you, please.
Yeah, sharing my screen now. Thank you. Thank you, sir. Is my screen visible? Can everyone see my screen, please? Yeah. Okay. So, yeah, I'm going to cover the diagnosis, classification, and pathophysiology part for osteoporosis. So, as just to give a brief introduction, I think we all know what osteoporosis is, but to put it in words, osteoporosis is a systemic skeletal disorder in where there is low mineral bone mass, and that causes microstructural or microarchitectural deterioration, and that decreases the number of trabecule coupled with thinning of the trabecule, and that then together causes compromised strength, leading to fragility fractures. So why is osteoporosis so important? The reason why we are discussing osteoporosis is it is very common. So 1 in 2 females and 1 in 5 females older than 50 years will have osteoporosis. It is painful. If there is an osteoporotic fracture, as we all know, it takes weeks or even months for these patients to get rid of pain. They seek for treatment. Even after treatment, they are still in pain. So yes, it does take quite a toll on their health. And then it can also lead to structural deformity like kyphosis or kyphoscoliosis. So yes, painful. And it is expensive. Now, as we'll discuss in the later part of this talk, the medical and surgical management, even the medical management with all the drugs that we'll discuss are expensive. And then it is deadly. What it means is a 30% people with hip fracture and 10% with spinal fracture will die in less than 1 year. And those who are going to survive will have some functional loss. So how do we classify osteoporosis? Osteoporosis is classified as primary. Primary meaning it will happen as we all age, or in women when they have menopause, they are more disposed, as we'll see in the pathophysiology part. So that is primary osteoporosis. Secondary osteoporosis is osteoporosis because of some underlying disease or some underlying pathology or some underlying factor like drugs. So secondary can be because of medical disorder like endocrine, rheumatoid arthritis, or GI disorders that can cause malabsorption. The patient might be on some medications for epilepsy or chronic consumption of corticosteroids, or even alcohol intake with more than 3 units per day and current smoking. So these are all secondary factors which can cause osteoporosis. Coming to diagnosis, how we diagnose osteoporosis, we all know the DEXA is one of the commonest form we all know can come across DEXA reports, and it still remains one of the gold standard for diagnosis of osteoporosis. There are other modalities like quantitative CT scan and quantitative ultrasound, but they are not recommended for diagnosis or for monitoring of osteoporosis treatment. So in DEXA, what do we look at? There are 2 things. One is the T-score, another is the Z-score. So T-score is how much the patient's bone mass is deviated from that of a healthy young adult. So if the deviation is between 1 to 2.5 standard deviations of a person with healthy bone of a healthy young adult, then it is osteopenia. If it is more than 2.5, then it is osteoporosis. So the standard deviation will be less than minus 2.5. Z score is the bone mass of that particular patient when it is compared to an age-matched population, a person of same age and sex, if the Z score is less than two standard deviation, meaning, sorry, more than two standard deviations, then we should look for underlying secondary causes that we just discussed. Why is this person having increased or predisposition to osteoporosis? So Z score helps in that, especially secondary osteoporosis. And based on this information, the WHO has classified osteoporosis into osteopenia that we just saw between -1 to 2.5. Osteoporosis is less than 2.5. And severe osteoporosis is when it is less than 2.5. And along with that, there is a fragility fracture. So DEXA does, when we interpret DEXA as clinicians, we do need to consider few things that we'll discuss. Now look at this DEXA scan that you can see on the screen. There are three photos. The extreme left, A and B, you can see that there is increased sclerosis at the L4, L5 end plate. And that increased sclerosis is causing increased recording of T-score in that region. So the DEXA doesn't understand this. So DEXA just will show wherever there is increased calcium deposition, it is going to show a higher T-score. So the calcium deposition can be because of anything. So it can be gallstones, it can be renal stones, or calcification in the aorta. So any of these factors will spuriously increase the T-score in that level. Again, in diagram C or the DEXA C, you can see that there is this patient is of ankylosing spondylitis, and there is increased calcification in the interspinous ligament. And there is a much higher T-score recorded in such patient. But we have to understand that this is not the true DEXA scan, the true T-score, and the patient might still have osteoporosis. So the common artifacts, as we just saw, is osteophytes. There can be some severe large osteophytes in some patients with degenerative changes that can cause increased calcium and hence increased T-score, but the patient might overall be osteoporotic. There can be vertebral fractures with some sclerosis that again can result in higher T-score. Spinal fusion leading to increased density in that area, particular specific, can cause higher T-score, and again implants. Or if the patient has had GI contrast or calcification anywhere around the spine, be it pancreas, kidney, liver, all this can cause increased T-score in that area. So it has been noted, this is an interesting fact to understand, that 50% of women with vertebral fractures are not osteoporotic by BMD. What it means, if we just rely on the bone marrow density, then we might miss the risk of vertebral fractures. So we should not just rely on BMD or DEXA scan to assess the overall risk of fractures, but rather the patient should be considered as a whole, and the risk of fracture in that particular patient should be assessed, which we standardly do by the WHO FRAX tool, which looks into or takes into consideration the other factors as well, like what is the age of the patient, is there any fracture of history in the family, or the patient has any previous fracture, are there any drug intake, current smoking, and alcohol. So all these factors should be taken into consideration when you are assessing fracture risk for that particular patient. So what are the so to not miss that, whom shall we screen? So the recommendations are we should screen all the ladies who are 65 or older, all the men who are 70 or older, that people between 50 to 69 with clinical risk factors that we just discussed in the secondary osteoporosis. So if there are any such factors, and if their age is between 50 to 70, yes, we should screen them as well. And patients with after 50 years of age with fragility fracture, and menopausal women with FRAX of 9.3 or higher. So what are the contraindications for DEXA? Pregnancy, yes, because DEXA does have radiation exposure, but it is very, very less. Although the radiation exposure is less, we do understand for obvious reasons why in pregnancy we should not order a DEXA scan. And then if someone has had a recent GI contrast study, then that person needs to wait for at least 72 hours to have the DEXA scan. And if the body weight is excessive, the patient is obese and the weight is more than 120 or 30 kgs, which is the capacity of the scanner, in that case, it won't be possible. So let's understand how osteoporosis happens. What is the pathophysiology of osteoporosis? To understand that, let's just look at the peak bone mass. So the peak bone mass is the maximum density of the bone mass that a person will have in the lifetime. And that roughly is around the third decade of life. After the third decade, as you can see in the diagram, the bone density gradually declines. and see the difference between male and female. In females, roughly around the age of 50, 55, there is an acute decline. And that is where the menopause kicks in. And after the menopause, first 10 years are critical. There's an acute decline, and then it gradually declines. And what factors will determine? Yes, genetics does have some role to play. Hormones, as we'll discuss. Physical activity. Yes, if the patients are getting older, there's less biomechanical loading and hence less stimulus for bone remodeling. Diet, deficiency of calcium and vitamin D can also decrease the bone mass. So to understand the pathophysiology, there is a central, very key pathway that we need to understand. And I'm sure that the drugs or the medical management part that we are going to discuss further will focus on this. So to understand the mechanism of action of those drugs, you need to understand this rank and OPG signaling pathway. So let's look at this. Rank stands for the receptor activator of nuclear factor kappa, and rank L is its ligand. So one is the receptor and one is the rank. And then OPG is osteoprotein protein. So to explain this, I will just bring up this diagram. It's a bit complicated, but we'll simplify it by considering one part at a time. So let's just focus on the left part of the diagram, which is an osteoblast. So this osteoblast or the stromal cells, look at its surface. What is it expressing? It is showing rank L, which is the rank ligand. And then look at the next cell, which is the osteoclast precursor cell. That is expressing rank. So when rank binds with rank ligand, this binding or this interaction will send signals to this precursor and will stimulate it to differentiate into an osteoclast. So the osteoclast will get differentiate and then start its action, thereby increasing bone resorption. Now, this OPG protein you can see here, osteoprotein protein, this protein will inhibit this interaction. So rank and rank ligand binding will be inhibited, and hence there won't be differentiation and there won't be remodeling. So it is negative regulator for remodeling. Now, similarly, if you can see this molecule here in the green, MCSF, macrophage colony stimulating factor, something similar to rank and rank L. This is secreted by the osteoblast, and this binds with the receptor on the osteoclast precursor. This binding also will stimulate the precursor to differentiate into an osteoclast, thereby stimulating remodeling of bone. And then we can see that sex hormone, bone morphogenic factors will stimulate osteoprotein, which will inhibit this and therefore prevent osteoclast, whereas parathormone, interleukin 1 and glucocorticoid will stimulate the osteoclast activity. So with that, let's look at primary osteoporosis pathogenesis, which is we just discussed, senile and postmenopausal. So what happens in postmenopausal? There is decreased estrogen. Now, decreased estrogen will cause increase interleukins 1, 6, that will increase the rank ligand and decrease the osteoprotein. So that all this together will stimulate the osteoclastic activity, and decreased estrogen will promote bone resorption and promote bone formation, but the bone resorption is much, much higher than bone formation. Hence, it is a high turnover osteoporosis. So postmenopausal osteoporosis will be a high turnover osteoporosis because more of the bone is resorbed and more of the bone is formed, but resorption is more than formation. So women with menopause in the first 10 years will have up to 2% of cortical bone and up to 9% of cancellous bone lost each year. Whereas if you look at senile osteoporosis, what happens here is there is decrease in everything. So the replicative activity of progenitor cells is decreased. The synthetic activity of osteoblast is decreased. The biological activity of matrix-bound growth factors will decrease. The physical activity of older patients are less. So there is less biomechanical loading. Hence, that stimulus is also less, and thereby remodeling is less. So all this together will result in lower bone formation, and hence this osteoporosis is low turnover osteoporosis. So in senile osteoporosis, there is both subperiosteal thinning and trabecular thinning because of subperiosteal resorption and endosteal resorption. Both the part, which is the cortex and the trabecule, both are thinned. Whereas in postmenopausal osteoporosis, it is mainly the trabecula that are thinned. So these two are the primary osteoporosis, and the pathogenesis, I hope, is summarized in a network that was clear. So with that, I will just focus on these three take-home messages, that osteoporosis is a silent disease. Sometimes it is not diagnosed, or it is not in the picture unless the patient has a fracture or comes with pain. Under diagnosis, yes, there is I don't remember the exact numbers, but yes, it is highly underdiagnosed and highly undertreated. We need to educate the patient and society and stress on the importance of completing the treatment that we'll discuss, because in our scenario, the patients may not come always for follow-up, but it is very important in the first visit that we stress this. And we should not rely only on the BMD, but we should assess the fracture risk overall and then treat the patient. Thank you so much.
Thank you, Rakesh. Thank you for this comprehensive lecture.
Thank you, sir.
You said that DEXA scan will be misleading in cases where there is excessive osteophyte or calcification of the ligament.
Yes,
So
sir.
in these cases, will a QCT be not appropriate investigation?
Yes, sir, definitely.
Because that
I
kind of
agree,
will give the transverse cut of the bone.
Yes, yes, definitely. It will help. And in that case, then obviously there's the cost and the radiation exposure is the only downside, as long as the patient understands and the doctor understands why we are doing it. And if that is going to change the treatment plan, then I think, yes, it's a sensible thing to do.
There are some new literature coming up which are kind of, relying on the MRI also for, they're comparing the MRI scores with the QCT and DEXA. So maybe in the future, we might not have to send the patient for DEXA scan, and they can come with the MRI report itself, having a
Right.
osteoporosis grading,
Quantification. Yeah.
in the near future.
Thank you, sir.
Deepak, any question for Rakesh?
Yeah, can you hear me?
Yes, yes, I can.
Yes.
Yeah. No, I think it is. There's no question, because we know, ultimately there's no final answer, because the quality of the bone can be assessed with MRI, CT, but I think still now the BMD is the only thing which we rely initially for evaluation, and then if we have to operate, then we can get QCT and get the exact quantity of bone at that level.
Thank you. Shiblee, can you please start your lecture on medical management of the osteoporosis? Thank you. Rakesh, have you unshared your screen?
Yes, sir, I have. I have unshared, yes. I have stopped my sharing already, yeah.
Is my screen visible?
No, we can't see it yet, Shiblee.
Yes.
Are you facing any issues, Shiblee?
I'm not able to actually get connected.
So you have to click on the share button, and then it will show all the windows open on your desktop. And you'll have to choose the window which you want to show.
Here on the share.
There's a share button at the very bottom. Are you on the phone or on the?
I'm on the this thing iPad. Oh, sorry.
Pardon?
I'm on this Apple thing. So desktop one.
Poonam, can you please guide him?
Sir, first open your presentation, and then at the
It
bottom,
is open.
at the bottom, you can see green icon. You can click on that share option.
See, I have gone to share.
Share entire screen.
allow Zoom to share. Open system setting. So it goes to setting area.
Are you on the iPad, Shiblee?
Yeah. Yes. I'm on the iPad.
Okay. Can you try to, is there an access for laptop or any other computer for you over there?
Computer, yes, there is. So can I join
So,
from there?
yeah, but that will be fine, because that's easier.
Okay. I'll do that. So do I need to exit from here and join from there?
So
Yes,
doesn't
sir.
matter.
Okay.
Deepak, I was thinking of having your talk first, but I think it will make sense to go in sequence only. Medical management followed by surgical treatment. We'll we'll have to wait, I think, for him to start. Let's wait for 2 minutes. Not happening, Shiblee? You are on mute. Shiblee, you are on mute.
So please unmute yourself.
Deepak, I'll call him, and I think he was trying to enter from some other thing.
Recording in progress.
Shiblee, log out from one of the device, please. The other device.
Yeah,
Otherwise,
I'm just logging out from my phone.
yes. Deepak, I think we'll let Shiblee figure it out. Let's start with your talk on the surgical management of osteoporotic spine fracture.
And then just share the PowerPoint.
We can see it, Deepak. Go ahead.
Yeah, I just want to make it this. All right, can we see it and you can hear me?
Yes, both.
So I'm starting. So I'm going to talk about the osteoporotic fracture of spine, the surgical management. One has to understand that the osteoporotic fracture of the spine has a in the normal course, the pain would gradually decrease, and then in about 6 to 8 weeks, the patient will have a relatively pain-free situation where he is able to stand, walk, go to the washroom, and doesn't need any support or any other issues. But then what is the biggest issue with the osteoporotic fractures is that there's so much of confusion and neglect that what to do, when to operate, when not to operate, and how to operate. And one of the reason is that in majority of the cases, patients get better without any intervention. And because they get better without any intervention, the general orthopedic surgeon does not have any clear-cut commandments what to follow. So they conserve all the patients, and who don't get better, they keep on conserving. Just a second. Yeah. How do I move? Yeah. So, but 15% of the patient will not follow a normal path of recovery. They will follow either of these two paths. One, either the patient will keeping getting better, but at 6 weeks, they start having more pain, and then they keep on worsening after that they have limited mobility, more pain, radiating pain, or they just have some improvement and then they never get better. These are 15% of the patients who will not get better, and these are the patients who have basically a progressive collapse, which happens in about 30% of the patients. 13% of the patients will go into a non-union because of the necrosis of the vertebral body. And out of that 100%, 3% can also have a progressive neurological deficit. And I compare the osteoporotic compression fractures who are not doing well are worse than hip fractures because they cause more disability, and such patients have poor activity of daily living. Such patients will have pulmonary problems, bed sores, and it's very difficult to take care of such patients. And the mortality rate is increased by 15% of such patients. So as we are very aggressive about the hip fractures, that we have to operate the hip fractures no matter what, such patients who are not improving also have to be treated aggressively. So what are the patients whom we would like to operate if they have an osteoporotic fracture of spine? One is osteoporotic fracture, which is very painful, restricting the movement. Patient is not able to go to the washroom, not able to sit and eat. Such patients stop eating. They can't take care of their daily needs, are dependent. They have progressive downhill course after the initial recovery. And they can also present with symptoms that they were getting better, but now whenever they try to get up, they can't bear weight because there's so much of instability. When they bear weight, there's pressure on the nerves, and the nerves can't take weight, even if they have the proper power when they're lying down, or they have developed a new neurodeficit. So a patient who has an outright unstable fracture, or who has developed a pseudoarthrosis, or has progressive instability leading to neurodeficit are the candidates for surgery. So if you see a CT and you have a clear-cut involvement or osteoporotic fracture with a posterior involvement, these are the patients who have to be treated aggressively. But that which patient need a surgery and what surgery and which patient do not. So the closest we have come till now is a AO spine DGOU classification for osteoporotic fracture spine. These was developed by the German Society of Orthopedics and Trauma. They have worked in a big group for about 10 years and have come up with a classification which divides the osteoporotic fracture into 5 subgroups. But to have reach this classification, we have to have conventional X-rays in standing position, both AP and lateral, MRI of the whole spine, especially the stir images, and the CT scan. All these things are needed, and you cannot do without one. And so it makes it a very expensive classification from Indian point of view. But this is very helpful. So in type 1, you will not see any fracture in the CT or the X-ray. You will just see edema in MRI stir images. There is no vertebral deformation. Type 1 fracture is detected just on MRI, and it's a stable fracture, which probably does not need anything to do. Type 2 fracture is basically deformation of the superior end plate. The posterior wall is involved less than 1/5 of the height. This is basically an impression fracture and are considered fracture. Now, above that, type 3 fracture is a fracture of only one end plate involving both anterior and posterior wall, and the posterior wall is involved more than 1/5 of the height. These are basically incomplete burst fractures, and these fractures can be stable and can collapse over time and have to be monitored. Type 4 fractures are basically fractures in where the vertebral body has basically, there is a complete burst fracture, and the whole vertebral frame and the structure has been lost, and both the end plates are involved. And with time, they basically go into these three types. One, when they develop an intravertebral vacuum cleft and a non-union, or they have become a vertebral planar type of situation, or there is a complete burst fracture with a superior inferior end plates, or a pincer type fracture. In type 4 fractures, basically the body does not have any structure to support, and they are highly unstable. Type 5 are the one with osteoporotic fracture with distraction or rotation. There is injury to the anterior column as well as the posterior column. They are outright unstable fractures, and they need aggressive treatment. Other thing about the OF classification, OCF classification by DGOU is that the fracture severity is always evaluated on follow-up. So if on the follow-up, if the fracture grade has increased, then we will take the final grading as the score and we will decide the treatment on that. So the first impression is not the last impression. It's the last X-ray which decides what you have to do. Then we can also use a OF score by the same group, which not only uses the osteoporotic classification of fracture, but also sees the severity of osteoporosis, deformity progression, pain, how much is the pain even under analgesia, and the health status, taking in view the ASA classification, BMI, nursing help, and well as anticoagulation. By adding and subtracting these scores, if the score is more than 6, it's an outright case of surgical treatment. Below that, it's a conservative treatment, and 6 is basically indifferent. You can decide according to the situation. But if I have to discuss the surgical management, I would say surgical management is broadly into two categories. One, either you do a percutaneous cementing technique, vertebroplasty or kyphoplasty, or you do a posterior fixation with some sort of an anterior support, and if needed, a decompression if there is a cord compression. Before we decide what we have to do, a dynamic mobility X-ray really helps us deciding the procedure. It is basically, we compare the standing lateral X-ray with a supine cross-lateral extension view like this. And how it helps is what results are we going to get on table. But I do not do this X-ray because this is painful and needs monitoring. I rely on MRI and the CT. A CT or MRI is a supine view. It really shows how much is it opening up. If there is a fluid inside, a cleft inside, it gives me a good view whether it's a mobile fracture and whether I will be able to put a cement or not. For the cementing technique, the vertebroplasty in general means we are just injecting the cement into the vertebra. So there's nothing big to tell about it. It's normally used if we do not do cementing immediately. We normally wait for 6 weeks for the fracture to settle and the pain to decrease. But if the pain is unbearable and patient is so immobile and in pain that she's not moving, she's developing bed sore, she's urinating on the bed, not able to eat, such things can be threat to life and you have to intervene earlier. These are mostly type 3 DGOU cases or someone who has developed a pseudoarthrosis without involvement of the posterior elements. Kyphoplasty is a step further in which you just go in and inflate a balloon, create a space, and then inject the cement in that space. Nowadays people are using stentoplasty, in which you open a balloon and then use a stent which keeps the vertebra open and then inject, with the added advantage of a structural support besides the cement. The technique of vertebroplasty, I will not go into details, but a short thing that the entry has to be from the upper and outer quadrant, and one should avoid violating the inferior and medial part of walls of the pedicle to avoid any nerve or cord injury. And we should always take a lateral view to know in what direction we are going. And needle position should be confirmed in both the projection before we inject the cement. In the AP, the needle should be in the middle, and in the lateral, it should be in the junction of the anterior and middle third of the vertebral body. Small tips that once the cement injection should be performed in the lateral position, not in lateral projection and not in AP projection. Goal is to deliver the cement equally in the targeted area and deliver the cement at a controlled place and not put too much of pressure, because if you're putting too much of pressure, it might shoot out and go into direction where you don't want it to do. And once the cement is injected, you should slowly pull the needle back so that you can evenly distribute without putting too much of pressure in one particular area. To minimize the risk of cement leakage, the PMMA should be injected when it reaches the consistency of a paste. So we have to be really prepared for it, and then you just take a few minutes to do all these things. Injection of cement is discontinued once cement reaches the posterior 1/4 of the vertebral body. That point has to be kept in mind. If there is any leakage into the vein, stop there, let it settle, let it cast the vein, and then inject after some time. In the meantime, you can inject on the other side. Or if there is a leakage outside the vertebral body, there itself you should stop, pull the needle back, let the cement harden, and inject in some other area. In short, you can do vertebroplasty or kyphoplasty in local or general anesthesia. Start at a 10 o'clock and 2 o'clock position. Even though I use any needle which I get, but it is recommended that for lumbar use 11 gauge needle, for dorsal 13 gauge needle. A multi-beveled needle is preferred because it does not slip. A single bevel has a tendency of slipping over the bone. The amount of cement, if injected less, will not give support. If injected more, has no advantage but can cause embolism. So from T3 to T8, 3.5 ml, from T9 to T12, 5 ml, and from L1 to L5, 6 ml of cement is sufficient enough. You should stop when the cement reaches the posterior quadrant and aim for getting equal distribution in superior, inferior, and AP, anterior posterior part of the vertebral body. Aftercare, you have to let it settle, let the patient lie for 2 hours, and then he or she can walk. There will be some pain in first 1 or 2 days, for which you can give muscle relaxant or physical therapy or heat therapy. The biggest complication which we fear is cement leakage, which is very high, which can be about 30 to 40%, but most of them are asymptomatic and you can ignore it. Sometimes the cement can emboli into lungs. It is more in case of vertebroplasty and less in kyphoplasty. Very rarely it can go back into the canal and compress the spinal cord, but it is very, very rare and one have to be careful about it. Infection can be there, which is rare, but most common is adjacent fracture, because once you make a vertebra very, very rigid, then the upper bone, which is softer, has a tendency to get into more fracture, which can be 12 times the risk of a normal vertebra. In short, both vertebroplasty and kyphoplasty are safe and effective procedures with equal long-term pain relief and functional outcome, and equal incidences of adjacent vertebral fractures. But kyphoplasty is little superior because you inject more volume of cement, you can get kyphosis correction short-term and long-term, and lower risk of cement leakage. But kyphoplasty takes longer time because you have to inflate the balloon, you need more infrastructure, and the cost is more. So we cannot really say which one is better or not. There was a time when all the fractures were treated with the kyphoplasty and vertebroplasty, but after 2009, there were so many randomized controlled trials which showed that these are unnecessary. Now we don't use them as often for treatment, and we only use them judiciously. So after the few trials, it has been proved that they are effective, but you have to use it judiciously in cases where it is really needed and beneficial. So this is one of the case in which there was a fracture of the anterior and posterior wall and upper end plate. Patient also had rib fracture, was immobile because of a lot of pain, needed pain relief. We took the patient under local anesthesia, injected the cement. Even I had, you can see leakage into the vertebral disc as well as in the lateral part, but patient did not have any other symptoms. The VAS score immediately improved from 9 to 2, and patient had good pain relief, and I think it was beneficial for this patient because he had rib fractures also. This is another patient, 78-year-old female, with pain of 3 months duration, and it was always on getting up from sitting position. So she wasn't able to turn in the bed, not walk, and not getting better. And on X-rays, there were two fractures, but one at L2 and one at L4. But on MRI, it was confirmed that it was the L2 which was the culprit because there was a fluid level over there and there was contained pseudoarthrosis. And all this needed was a good vertebroplasty cementing in that area, and she did well. The other case scenario is when the healing has stopped and patient comes with either that I was able to walk now and whenever I get up, I can't bear weight, I have radicular pain in the chest or in the legs, and patients sometimes develop a neurodeficit. In such patient, posterior fixation is also required with or without decompression. But before we decide on that, we have to look for, there are challenges in such patients. Frailty because of the age and comorbidities. There is a posterior wall breach, which does not allow us to do cementing without any risk. Bone quality for implant fixation is very poor. Anterior support or reconstruction is required, which is a challenge. Then we really don't know how many levels to fix, whether we want to put screws or not. So these are the challenges which has to be decided by a surgeon. As far as the fidelity is concerned, one has to be mindful that because these are old patients and the surgeries are done under GA and in prone position, the risk of cardiac and pulmonary complications are high. And one has to really think about it before we decide. Risk of infection is high in such patients because of poor immunity. They have sarcopenia, which gives them poor outcome. These patients are diabetic, have other problems, taking steroids for a long time. So all these things have to be discussed with the patient, discussed in your mind. Risk-benefit ratio has to be considered. Other is the posterior wall breach, but I really find that this is overrated because if you find a pseudoarthrosis or if the patient is coming after some time, there's always a membrane around it. So we used to initially not leaking, we used to put a cement into the vertebra. But I think this is more or less solved. For increasing the screw purchase, you can either put a bigger diameter screw which engages into the pedicle and gives good strength. You can increase the depth by having a bicortical hold. You can use a conical shaped screw, dual threaded screw, or V threaded screw. All these things and permutation combinations can help you increase the screw hold. But in my practice, I just believe in cemented screws. Either you can use a solid screw vertebroplasty, which means you do a pilot hole, inject a cement, and then inject a solid screw over it, or the fenestrated screw is inserted and then inject the cement over that. If we look at the data, it is very clear that a solid screw, which means a non-fenestrated screw, has a 40% greater strength than a fenestrated screw. But a cemented screw, if it is a solid screw, has 4 times or 461.7% more strength, or a fenestrated screw has a 3 times more strength than an unaugmented pedicle screw. So the cemented screws are definitely much better in such situation. Fenestrated screw not only has less strength but also more prone to epidural lock, leak. So I would prefer a solid screw instead of fenestrated. Other options are sublaminar wire because the hold is on the cortical bone, so they have a very good hold. So if you are not able to do a pedicle screw, a sublaminar wire can help. Even better is a Marcelin bar tape, which has high strength. It can work like a sublaminar wire over a lamina, soft, flexible, and most important, it is thin and does not cause any neurological damage and less chances of cutout because of the high surface area. The principle of fixation or of, surgical treatment will be fixing the instability, anterior support, and plus minus decompression if the patient needs it. That can be done either by an interior approach in which you do and go through the chest or abdomen, do a decompression, cage fixation, posterior fixation, or you do a posterior approach, long fixation, short fixation, laminectomy, anterior cage or vertebroplasty through the posterior approach. Or third option is that rather than doing any vertebroplasty or cage fixation, you just do a osteotomy or PSO, compress it, and then do a decompression and fixation. So these are the things you can do. But in principle, if you don't give good anterior support, no matter what screw you use, what alignment it is, even the cemented screw can fail. So anterior support in such cases is mandatory. If we go through the anterior approach, that's a long duration surgery, blood loss, need ICU. So in my personal opinion, I avoid doing such big surgeries in old patients because they cannot handle it. A long construct can be used, but they have their own disadvantage because it produces a cantilever effect. You can see in this patient, there is a patient has basically bent over the construct and there is a new fracture. So I avoid a very long construct also. So ideal procedure, if you are doing a fixation, it should be least invasive, very small duration of surgery. Maybe you should be able to do a surgery in 1 or 2 hours, minimal blood loss, no peri-implant complication, fast recovery, and good neurological outcome. And the technique which I use in 90% of the cases is just make tracks, do a vertebroplasty after confirming there is no dye leak, put screws above and below. If needed, do a decompression and posterior lateral bone grafting with implanting. And just a case, this is a case of 72-year-old was getting better. Now is not able to, has very painful. There is pain all the time, cannot sit, cannot eat, is now room bound, and you can see a collapse. This collapse was immense, and I had prepared a cage, but and there was all the walls were fractured. There is no support anteriorly. But MRI really gave me some hope because I could see that the alignment was getting better. There was some space being created. And once I put the patient in the prone position under anesthesia, the vertebral body kept on opening up. I could do a good vertebral body reconstruction. This is the pre-op and post-op, and you can see how well the height is restored with just a vertebroplasty. And this is how the vertebral reconstruction was done. So the cement is giving anterior support. You can fix it with cemented screws. And I have a follow-up of 4 years of this patient, and this patient is really, really doing well with no further HN level problems. This is another case in which you can see there is a cleft. And whenever there is a cleft, you think, there is no anterior support. But when I see this fluid, I know if the fluid can be retained in this, then even the cement can. And this patient was treated with a cemented fixation with the vertebroplasty, and this cement gives a very good anterior support. Sometimes the patients are old, patients do not have a neurological deficit, and you get this situation, they can be treated with a fenestrated percutaneous screws with vertebroplasty, and it gives them early recovery with least morbidities. Just examples of vertebra plana, which can be treated with the same technique, just relying on positioning and opening up and the pressure of the cement. Another case of vertebra plana being treated like this, and this gives a phenomenal reconstruction. But sometimes you get a situation. This is a patient who was treated by a pain physician. Patient had a fracture of L3, severely osteoporotic, and they did a cementing first. This is just like an empty vertebra, and the patient just had nothing, and you could not do any vertebroplasty. This needed a proper anterior reconstruction and proper fixation because the patient has lost all anterior support. I decided to use an OLIF approach in this patient so that I could put a large cage. And this is a large cage I could put with bone graft and superior inferior fixation. And trust me, this patient has a follow-up of 3 years now. He developed fractures at upper levels, but this construct was retained. And last is the situation of neurodeficit. This is incidence is 2 to 3%. and it is though rare but happens so slowly that we lose time to make the right treatment decision, and happens from 1 week to 12 weeks after the fracture. And this happens because there is instability and the body tries to throw in new tissue to compress the cord. This is a 65-year-old female who had minor fall 4 months back, developed a progressive weakness with power 1 in the left leg, power 2 in the right leg, bladder retention. There was a previous fracture, but now the culprit was this, which was evident on the MRI. The MRI shows a compression here, and this was the first MRI, and the next MRI showed the compression had further worsened. There was a pseudoarthrosis. There was a cleft on the CT. We went in, removed the fluid, did a vertebroplasty, a laminectomy to make sure the cord gets some breathing space, and a fixation. And this patient is now 7 years follow-up. She's able to walk, do everything. There's a story behind it, but she's doing very well. Another patient who had a fracture with weakness, and this was treated with this. I mean, no one would do a vertebroplasty here, but I feel very confident giving anterior support with vertebroplasty when I see the fluid. And once we kept the patient in the prone position, see how it's opened up. We can, once the fluid is taken out, there is an empty space and reconstruction. I have published this too. So my treatment algorithm in summary is that if you have OC fracture and you classify according to the German classification, if it's type 1 or type 2, they are stable, conserve, follow up. If they worsen to type 3, do a simple vertebroplasty, kyphoplasty. But if they worsen to type 4 or 5, then you need a posterior fixation, preferably with cemented screws. If the patient is outrightly on day 1 type 3 and the patient is not getting better, the patient has pain and disability, very difficult to take care of such patients, do a cement fixation. Otherwise, if they're doing well and improving, do a conservative treatment. If on day 1 it's an outright unstable fracture, type 5 and type 4, it's better to do a vertebroplasty, kyphoplasty plus posterior fixation and cementing. My take-home message for everyone is that surgery for osteoporotic compression fracture can be life-saving, and we as spine surgeons should have that attitude. We should be convinced within ourselves that such patients are very difficult to take care of. You can take care of a 5-year-old baby, lift and wash, but you cannot. It's very difficult to handle 80-year-old with 80 kg of weight. So don't deny surgery, but evaluate the risk-benefit ratio and discuss with the patient. Choose treatment after proper evaluation of symptoms and anatomy. Execute the procedure well. Don't compromise just because the surgeries are expensive. And trust me, surgical choice won't disappoint you and the patient. Thank you.
Thank you very much, Deepak. That was a very detailed talk about all the aspects of the spine surgery. To start with, I have a question. You said two terms, the cemented screw and fenestrated screw. So
Yes.
what do you mean by cemented screws?
So, no, cemented screws can be divided into two types. Either you use a solid cemented screw, which means that you make a hole just like a normal screw, inject the cement, and then put a solid screw over it. And fenestrated screw is that you put rather than a solid screw, use a fenestrated screw and inject the cement with pressure over it.
And have you used both kind in your
I
practice?
use both
Or
kind, both.
did you see any difference in terms of, their, I mean, obviously
No.
we are not about strength, but in terms of loosening in the post-op period, did you see any difference?
Yes.
Why you moved
So,
to, because it's common practice to do fenestrated screws. Why you move to these, what you're saying is cemented screws?
So my first, the only reason I moved was to save the money.
Okay.
That was my real reason. But then I read the literature a lot, and I also observed my complications or the things. First of all, the cement, honestly speaking, I have not seen cemented screws loosened unless you really don't have any good anterior support. With the fenestrated screws, you have to use a lot of pressure, and I see a lot of epidural leaks with them, but I don't see that with a direct injection of cement. So I feel more comfortable
Okay.
when I'm directly injecting the cement. Yes.
So at what stage you put the screw in of the vertebral of the cement setting? What stage you like, when it's in the pasty stage, or as soon as you put the
Pasty.
cement in? No,
No,
the
once it become so I inject in all the, I make the track holes in all the things, see the track holes, inject the cement in all of them, whatever the cement I have, and then all the screws are ready and immediately put the screws in the pasty form.
when the
Once it is
when the
pasty.
cement is still pasty,
Yes.
not
I only have that 2 minutes time to put all the screws. That is the most crucial. That is the most irritating part of the surgery.
okay. Rakesh, Shiblee, any question for Dr. Deepak?
So have you faced any such complication where you try to insert a screw where you have put a cement and screw didn't go in, or is there any sort of uh, how do you decide the connection between the cement inserted and the screw you have put in? Is it strong enough?
So, I mean, there are two parts of the questions, I think. One is that, is it strong enough? I'm confident about it. I am actually now, finding my own data, and I think I've put a lot of cemented screws, and honestly speaking, they have really not loosened. So it means they're very, very helpful in these osteoporotic patients. So on table, I don't check the grip because I can't, because it's in the pasty form. I don't irritate them at that time. But follow up, I have not seen them loosening. There was always a fear in my mind that if I want to change the track, I will not be able to change the track because the cement will not allow the screw to come out. That was my initial fear. But by mistake, once what happened was that I had inserted my screw, and the inserter got locked, and I started to remove it. I removed the whole screw. I realized once the cement sets in, it basically the thread, it basically does not stick to the threads, and you can even take it out. There's no problem with that.
Yeah.
And
Because
you were able to reinsert the screw in the same hole?
Yes. That gave me so much of confidence, and it happened by
Bigger size, same
serendipity.
size. Bigger diameter, same
Yeah.
diameter.
Yes. Same diameter.
because
I've not tried a bigger diameter yet.
because even in fenestrated screws, if for some reason you have to give an extra thread or tighten it, the cement, if there is the locking system where the cement has come out and gone into the bone, if that segment breaks, there becomes no role of the fenestrated screws or the cementing done. So how do you
Yep.
decide basically,
No.
okay, this is the end point of your tightening of the screws, and the whatever cement you have inserted, you have made a mixture and you have put it all together. There may have been time that sometime the cooling system, AC, or some issues or delaying in the procedure, your screw have wobbled or whatever. How do you decide कि fine ठीक है नहीं जाएगा ही?
No. So my thought process is different. I feel once the grip of the screw, cemented screw, is because the cement spreads into the whatever the trabecules are left, right?
Okay.
And that increases the strength of the screw hold, and it's not the direct hold of or the grip between the screw and this. So it is, you basically create more architecture where the screw can hold. So I don't think that that's an issue, that it will grip with it, and once you loosen it or tighten it, it is going to lose its strength. Yes, once it has become thick and settled, you cannot change the size of the screw or the length of the screw because it will be difficult to push through the cement.
So Deepak, just to understand the process more clearly, you have made the screw track, you have tapped the path, and at this
Yes.
stage you will inject the cement in. How do you inject the cement in, and how much in each hole
Yes.
for one screw?
That's very good. So I just make a track lengthy. I use a lengthy to make a track, use a ballpoint to check, and with the ballpoint I decide the length of the screw on table.
Yes.
What every one of us do. Then after tapping, I use something called as a bone filler device, which is used for vertebroplasty. That bone filler device has 1.5 milli, normally 1.5 millimeter of the cement can be injected through one bone filler device. I keep 3 or 4 of them on table. You clean them immediately and use ETO them and then use them again. The amount of cement injected is 2.5 ml on an average. In the thoracic vertebra, 1.5 to 2. In lumbar, 2.5 ml is adequate enough to have a cemented hole.
Okay.
Got it. Shiblee, it seems that you are ready with your. Thank you, Deepak. Thanks again.
Welcome.
Shiblee's talk
Thank
seems
you very much.
ready, so please go ahead.
Really sorry for whatever happened. I think my screen is visible now.
Yes.
So medical management, some of the initial slide is taken care by my colleague, Dr. Rakesh. So its definition, which have been taken care of, the risk factor, which Dr. Rakesh has mentioned, alcohol use, corticosteroid, calcium low, estrogen, menopause, smoking and sedentary lifestyle gives a good amount of risk factor. The important management of osteoporosis, it starts from the diagnosis or laboratory investigations. So basic blood investigation in the form of creatinine, calcium, alkaline phosphatase. Creatinine in order to assess the renal function, which would decide what type of medication to be given to an individual patient. Calcium, whether it is low, high. If it is low, it need to be repleted. If it is high, need to be considered a case of hyperparathyroidism, and necessary treatment had to be changed, the line of treatment basically. Alkaline phosphatase to be seen in order to rule out osteomalacia and Paget's disease. So vitamin D level, 24-hour urine calcium to rule out malabsorption and hypercalciuria. PTH level with the calcium. If PTH level is high, low, again to decide along with the calcium level in the blood. Testosterone level in men with osteoporosis, and 24-hour urine cortisol in a patient who have Cushingoid features and who are, or rather in patients who have been on steroid for a longer duration. So again, the investigation includes a DEXA scan, which decides how significant the bone or how bad the bone quality is. So management, the goal is to prevent the further fractures and one, to treat or increase the strength of the bone matrix. So pharmacologically, we have calcium, vitamin D, the basic supplements. You have biphosphonates, denosumab, teriparatide, calcitonin, nasal spray. You have some estrogen receptor modulators and hormone replacement therapies. So individually, let's start one by one. So calcium and vitamin D. So it is said that adults usually takes less than half in general of the recommended dose. Higher risks are observed in malabsorption, renal diseases, liver diseases. Calcium and vitamin D supplements shown to decrease the risk of the fractures. Calcitonin nasal spray. So in my practice, I have been using a lot of this nasal spray for initial 3 months. It basically binds with the receptors on the osteoclast, which increases the production of the vitamin D producing enzymes, leading to greater calcium retention. It has a shorter half-life. There are some cases reported of nasopharyngeal carcinomas of this thing, but pretty commonly used. It also reduces the amount of pain. It is definitely a sort of analgesia. It has an analgesia effect. Second most commonly used drug is the biphosphonates, which is generally the first line of management, and it suppresses the resorption. So it acts on the osteoclast, and it cannot be used in a patient who are renally impaired. So it reduces the risk fracture by 50% of the fractures. Multiple side effects. it has a specific indication by which it need to be taken. You need to advise specifically to the patients that before taking this, it need to be taken on empty stomach. Post you have taken this, you'll have a lot of water and should not lie down in order to prevent the esophagitis or regurg basically. And it has a long-term effect of taking it may lead to a fragility fractures and delayed fracture healings. Next most common drug is the teriparatide. It stimulates the bone remodeling by increasing the bone formation, which is usually used in moderate to severe osteoporosis, and it significantly reduces the fracture in the vertebral and the non-vertebral segments. So high doses of teriparatides in rats had caused osteosarcoma, but there are no cases yet reported in adults, or you can say in humans yet, but not to be given for more than 2 years with such kind of risk noted. So it is usually avoided in patients who have bony tumors or multiple myeloma. So it is usually avoided in such cases. Plus, it is expensive and daily subcutaneous injection need to be taken by an individual, which is sometimes a bit tiring and hectic for an individual to take it daily. So should not be given again, as I mentioned, hypercalcemia, multiple myeloma, bone mets, skeletal tumors, and the young patients who have a growing bones. Denosumab, recently the use of the denosumab has increased. The mechanism of action, it binds with the rank L ligand, which prevents the binding of the rank receptors on the osteoclast, and likewise it inhibits the osteoclast activity, or the basically the formation of the active form of the osteoclast. It need to be taken every 6 monthly subcutaneously, and so the risk factor or the one of the complication or the side effect, you can say, the tiring part of the teriparatide is basically dealt with the denosumab, which need to be taken every 6 monthly. And it is also approved in patients who in the women who are on breast cancer therapies, in men who are on prostate cancer therapies. So again, an advantage over the teriparatide. So potential side effect of this, it causes fragility fractures, osteonecrosis, and some increased risk of the infection. So when you are giving denosumab, you need to be very fine and necessary specific investigation of blood parameters need to be done regularly, at least every 3 monthly, in order to note down, because patient and likewise need to specify to the patient to manage accordingly and to report if there is any specific activity or going on in the body. In contraindication, if there is an hypocalcemia, pregnancy, and hypersensitivity to it. So selective estrogen receptor modulators. So raloxifene, it is basically used in a female patient who are around perimenopausal, majorly not used. Like I haven't used such thing. It has multiple side effects. It reduces the breast cancer cases, but it is more of thrombosis, hot flushes, and coronary artery diseases. So majorly it is not used by the orthopedic surgeon. Sometimes gynac, sometimes endocrine people may have used such kind of procedure around the perimenopausal group, but by the orthopedician, not yet much. So hormone replacement therapy, again, around perimenopausal age group, used by the gynac people, not by the orthopedician. Again, it has a multiple side effect. It is more thrombosis causing factors. It prevention, so adequate nutrition, calcium 100 to 12 to 100 or 1400 mg daily. Vitamin D goal level should be maintained around 50, and daily regular exercises. See, the direct stimulus to the body in order to strengthen the muscles and the bone is given. Likewise, the production of the necessary bone would be done. It's simple, as said. If there is a demand in a factory, even if there is no demand in the factory and you have the necessary stuff in the go down, still there won't be production done. So likewise, the demand need to be there, and that demand would come with the exercises, the mobility. So even if you're giving the supplements, please ask the individual to do the basic regular exercises, which would increase the demand, and likewise the utilization of these supplements and the drugs, which will have its effect. So, like as Dr. Rakesh has mentioned about the modifying factors, so discourage the smokings, discourage alcohol abuse, risk of falling should be avoided. I have planned for few cases, likewise, in order to decide which drug is to be taken in which individual. For example, I have this 39-year-old premenopausal female with long-term steroid because of asthma. Lab parameters: creatinine is fine, calcium is normal, vitamin D is low. DEXA scan shows Z score of -3.5. Next step of management. So here vitamin D is low, patient is young. So teriparatide and plus kidney function is pretty good. So vitamin D replacement, calcium replacement, and teriparatide at the initial level of treatment would help definitely. Second case here, 75-year-old female with multiple myeloma, has multiple compression fracture, was on biphosphonates for 5 years. Lab parameters, again, renal function is fine, calcium okay, vitamin D low, DEXA scan is also low. Here, what need to be seen is renal function is okay, but patient has multiple myeloma. So avoid teriparatide in such cases. So here, denosumab would give a better effect as the patient has already taken biphosphonates. Third case, again, 80-year female with kidney disease, osteoporosis, has kyphosis, renal function is impaired, vitamin D is okay, calcium is okay, and PTH is mildly elevated. So kidney function is affected. So you can't give biphosphonates. Again, PTH was high, so PTH injection need to be avoided. So denosumab would be a better choice of action. So likewise, you need to investigate an individual in order to decide the line of action. Last case, 70-year-old female with osteoporosis. She has not had any fracture and doesn't have any other risk factors, no history of tumor. Creatinine is okay, vitamin D is very low, normal calcium, and elevated PTH. Again, the elevated PTH rules out the teriparatide injections. Here, best would be to give biphosphonates in order to maintain or the correct the osteoporosis. So multiple combinations. Sometimes we have come up with multiple options. Okay, we have 3-4 drugs. Can we give it together? What combinations are better? So teriparatide and biphosphonates. Okay, there are multiple papers which shows teriparatide is better than biphosphonates alone or when used in combination. Okay, and no need for biphosphonates to be washed out, can start PTH immediately. Okay, so as mentioned, if PTH is given along with the biphosphonates, it has a lesser effect than giving PTH alone. But when you are stopping the biphosphonates, you can directly start the PTH. No need to wait for the biphosphonate to be washed out from your body. Next combination is denosumab and biphosphonates. So denosumab is better with alendronate than risedronate in increasing the BMD and reducing bone turnover. So you have to decide the ideal combination in order to have the best effect. Next is teriparatide and calcitonin. Though these hormones, both the hormones have an antagonist effect on the calcium level, but the pulsatile form or pulsatile injection of teriparatide is very much effective. So these two can be given together. Last, most commonly discussed is the teriparatide and denosumab. So there are multiple meta-analyses which suggest the combination therapy had led to an increased BMD at lumbar spine and in hip in comparison to monotherapy without an increased incidence of any adverse effect. So ideal right now, if patient doesn't have any sort of hypersensitivity and the teriparatide is on the lower side or normal, combination of teriparatide and denosumab is recommended along with the nutritional supplement in the form of the calcium and vitamin D along with the regular exercises. Thank you.
Thank you, Shiblee. So the main confusion I think we face nowadays is to give denosumab or teriparatide or both, or like in what combination. One of the problem which we frequently face is we give the patient option that there are these two kind of injections available which you should take because your bones are very weak. One you will have to take every 6 months, the other one you will have to take on daily basis. And the patient obviously will choose, most of them will choose the one to be taken once in 6 months. So we have to face this thing. But if the patient is ready, like for whatever treatment you are going to tell them, are you giving them on simultaneous basis or you are giving them in sequential basis?
So what I do is I usually starts with teriparatide, but sometime when the patient is not responding in a span of 2 months, usually you get a pretty good idea in terms of patients saying that they feel better or the generalized well-being has improved, generalized bony pain has gone down. So I continue with the individual teriparatide monotherapy. But if there is a complaint continuously there post 2 months, I decide for denosumab to come into the picture.
After how many months?
2 months. That's
After
my
2 months.
Yeah, after 2 months.
Rakesh, what do you do?
I usually prefer sequential therapy, sir. I would start teriparatide for at least about 12 to 18 months. And if the patient is non-compliant for some reason, then obviously switch to. But I think somehow, yes, I do appreciate the literature, but I'm not very sure of the combination therapy. I feel that it is not 1 + 1 = 2. There might be benefits of combination therapy. But I think for me and my understanding might be wrong, but sequential therapy does better than combination therapy, wherein you do one compound first, teriparatide, give it for a period of 1 or 1.5 years, maximum 2 years, and then we switch to denosumab, or you start with denosumab based on the clinical scenario, and then we switch to bisphosphonates, but no switching from bisphosphonates back to teriparatide.
So my basic concern regarding this is like we usually start these kind of treatment in older chaps, and for such patients we need to be a bit aggressive in terms of getting back to normal, then wait for a specific duration of treatment. So that is the only reason why I try to get in another drug so that we have a good effect. So as I mentioned, I wait for initial 2 months, and if there is a sign of improvement, because see, osteoporosis is a systemic disease. Okay, it is not about just treating an individual fracture. Patient with osteoporosis have come many of the time with generalized pain. Okay, so usually the bachus have come, the young kids or the teenagers have come with generalized pain here and there, upper back pain, neck pain, body pain. So you start with calcium tablets, vitamin D, and they do improve. That is again an osteopenia. Okay, likewise in an older chap, they come with generalized pain here and there, not feeling better, irritability. These are again a sign of osteoporosis. So this is an indicator, one of the indicator where what I assess at the end of 2 months, that their osteoporosis or bone quality or in general osteoporosis is improving or not. So and I decide accordingly, because what I think is we need to be bit aggressive in older chap in terms of getting back them into on their feet. That's the only thing.
Deepak, combination therapy or sequential therapy?
So I am very clear about it that if the patient has severe osteoporosis, if the patient is in the degree of -4, 4.5, you have to start combination therapy, because it is, even though it is not 1 + 1, 2, but it is 1 + 1, 1.5, and it is better. So if this patient is concerned about the osteoporosis, and if it is in the range of -4.5, -4, you have to give the option of combination therapy, and that should go as long as the patient can take. If I have to start with one therapy, it would be teriparatide, and then once the patient starts becoming non-compliant, then shift to denosumab. That would be my way to go.
What's your preference, Amit sir, if I may ask?
Yeah.
Okay, so I think we are done with the lectures.
What's your preference, Amit sir, if I may ask? What's your preference? What do you
like I said, like, a lot of it depends on the patient, because you tell them that there are 2 injections, so they naturally start thinking about, can I take one of them?
Yeah.
And one, obviously, the one in 6 months
6 months
turns out to be cheaper also and much more convenient.
Yeah.
But then I have to inform them that, like people who are diabetic, they have to take insulin on daily basis. You eat daily, you bathe daily, why can't you take this injection also daily? So preferably, I tend to believe in combination therapy. So I give them both if they can afford, plus if they are ready to take the injection. Basically they need to be ready for teriparatide. Denosumab, nobody minds.
Right.
It's cheaper compared to and it's once in a while.
Compliance is good. Yeah.
So if they are ready for teriparatide, they will be ready for the denosumab also. And for us, like us surgeons, I think most of the time it is used when we are done a surgery. We'll be using it, like some of my friends, they are saying that in last few years, their rate of vertebroplasty has gone down drastically because, as Deepak said, that many of these fractures, they come in the grade 1 and 2, and then they might progress to grade 3, 4, and 5. But nowadays, many of them are not progressing to these grades because you start them on these therapies, teriparatide and denosumab, etc. So I think in the past, obviously grade 3, 4, 5 patients who are coming, you are offering them surgical treatment only, but these patients who are coming in grade 1 and 2, and you start them on treatment, so probably they are not progressing. So those patients are being saved from having the vertebroplasty or kyphoplasty done. So I think many of my friends are saying that their rate of vertebroplasty or cementing has gone down significantly. Now, so obviously, like when we are treating these patients on OPD basis, we are giving them this therapy. But majority of the time, it's the post-op patient whom we have done the surgery, DEXA, Corvino, and the screw hold was, even after taking all the precautions of putting those sublaminar wires, cemented screws, and good anterior reconstruction, still we are worried about the next level or the other levels. So we tend to, and then it's not instrumentation, we want to fuse them also. So then we are the patient where we are trying to start them on some kind of, these therapies. So here I would like to give the patient best chance. And so given a choice, if the patient can afford, then I start them on both the like combination therapy. So thank you all. I do have a couple of cases. I think you have shown a lot of cases during your talks only. So maybe we'll discuss just one or two. So what kind of, and there will be surgical cases mostly. So just 10. Pardon?
I'll just stop sharing about. Yeah.
Yes, please. Yes, please.
Yeah, done. Stop sharing. तो बंद हो गया ये.
So this is a typical scenario. We see that 60+ female comes to the clinic and history of domestic fall. Complaining only of the low back pain since last 10-15 days, and there is no radiculopathy. there is tenderness in the thoracolumbar area. Neurological examination is normal, and this is what we see on the X-ray. So I think there are a lot of fractures in mid lumbar and thoracolumbar, and maybe some in the mid thoracic spine also. But I think, what do you think, Rakesh? What might be happening over?
Yeah, as is like there are two, three fractures, and the tenderness is at T11, as you mentioned. So probably there might be an acute one line fracture there. So I would wait and watch, treat conservatively this. So conservatively, I mean giving them something for the pain, and obviously getting a DEXA scan done to quantify and osteoporosis, how bad it is, if it is, and then start the treatment accordingly. And might as well add brace, but bracing is little. Some patients they're not very happy with the brace, so depending on how the patient compliance is, bracing might help as well. And then monitor them again at 3 weeks from the initial visit. My cutoff usually to get an MRI scan or to decide whether we need to do something is 3 weeks, I would say, and that is when we would see how much is the VAS score, how much is the pain, if there is any improvement, whether we need to do MRI with stir and take further decisions depending on that. So for now, conservative treatment, symptomatic management, follow up at 3 weeks.
How much of the bed rest or activity restriction?
I usually don't really like to put them on bed for like complete bed rest. I would usually say be sensible. Whatever basic activities you need to do, like going to toilet and all, that is fine. But avoid any jerky movements. Avoid travel. Avoid keep a good balance between rest and activity. But not I would strict bed rest I would not really recommend. But put a brace and then yes, rest, but not completely strict bed rest. So it is hard just to put in simple words, just be sensible. Listen to your body. If there is pain, then lie down, be flat. Don't load your spine with your body weight.
Deepak, complete bed rest or no bed rest?
So no, bed rest is a very wrong word, because if you tell them bed rest, they will taking rest for next 6 weeks and then
Yeah.
become like a wood. So
Mhm.
what I would add is that they should respect their pain and should try to be mobile. What I always tell my patients relative is that help the patient get out of the bed. Don't let her sit out of the bed on her own, and not allow them to twist on the bed, because that are very painful moments, and then patient become more apprehensive about getting up. But if we take care of that, they don't need any brace, no bed rest. I mean, they might just need bed rest for 4 or 5 days, and they should be better after 4 or 5 days.
So no bed rest and no brace also, correct?
No brace.
Yeah,
Yes.
I mean, the obese patients, especially females, are not very compliant with brace.
Not complete.
And it won't work also because there are a lot of
It doesn't.
fatty
Yeah,
in the
a lot of that.
Yes,
surface and
it
the.
doesn't fit. They just hang. It's just hanging there.
Mhm. Shiblee, brace or no brace?
No brace. No brace.
No brace. Okay. So this patient came back after 2 weeks again, and there was no improvement in the pain. So we got the MRI done, and this was the MRI, which showed that there was a fracture, old healed fracture at L3, but this fresh fracture was there at T12. So at this stage, what should we do? It's been already 4.5 weeks since the initial fall. Pain is persistent. Neurology is still intact. We can see that posterior wall is intact. So should we still wait, or should we offer patient something at this stage?
We have
Some sort of
stir images for this. We have. I mean, we can see the signal changes, but
we have just these two images, axial and.
okay.
There
Yeah,
Deepak,
there's some
instrumentation?
involvement of the pedicle.
Yep, yeah, we can see it over
So-
here. Yes,
My
right.
thought process would be that I would warn the patient that this is not a very good anatomy to heal. This has more tendency to collapse. So we can, and this looks that there is no posterior element involvement, and we can just go, get if the patient is willing, and we can get away with just cementing of the vertebral body.
Would you add a biopsy as well?
Biopsy is mandatory in all of the patients I do because, it's more not that I fear there is something. I just fear the medical legal. Sometimes, you miss
Yeah.
something else comes out and I just don't miss it.
Exactly.
So no neurology, stir images are there, but they are coronal cuts only. So we can see that this acute fracture is only at the T12. Rest of the vertebrae are okay. So we went ahead and we did the vertebroplasty. Now you see that very typical pattern of vertebroplasty. Like what happens that um, uh, if you inject too much of cement, it will start coming out of upper and lower end plate. And if you don't put enough pressure, it will not fill up the entire space. So what is the trick? How to make sure that you have enough cement without actually letting it spill out of this box of the vertebral body? Rakesh.
So to be I would just have my CM in lateral position and in continuous monitoring. What I usually do is injecting the cement, watching in a continuous shoot, and then slowly withdrawing my needle until there is still some space left, like 1/4 of the from the posterior cortex. That's when I will stop injecting. And to be honest, don't really fuss much about how much ml of cement I have injected. If I'm not happy where it is going, I would rather stop. Uh, I mean, we did so many vertebroplasties on our on calls in UK Nottingham, and we found that sometimes it's even 2 ml of cement does really wonderful job when it just comes to pain. When you're not really worried about the anterior support, if it's just the pain with the edema, even 2 ml of cement does the job. So to just contain it adequately, I would start little anterior, place my needle well in the center or where the cleft is, and then watch the cement filling continuously in the lateral shoot and stop. Like wonderful cases shared by Deepak sir, and when we did this vertebroplasty, even in cancer cases to provide anterior support, there was not much of the posterior cortex. And even in such cases, when the consistency is right, when you know when to stop, and you're continuously watching in lateral X-ray, I think the chances of leak are really, really rare. So more about feeling if you are going at the right place, continue. But when you have doubt, I would just stop and not worry about the amount.
What is the maximum amount you have put until now?
About 4 to 5 mLs in like L1 and in the lumbar. Thoracic, I have not gone more than 3 mLs, 3 to 4 mLs.
And one needle or two needle? One needle or two needles?
In 2 needles, total amount of cement. So just like 2 ml of syringe here and 2 ml of syringe here.
Bilateral.
Bilateral.
Usually.
When I have to do multiple levels, and then would put a left, right, and then would just inject one needle, place it, really converge it after crossing the medial wall, and just do it with one needle.
So one of the things I have started doing recently is that before I inject the cement in, I take a diluted urographin dye and I inject it. It gives me some clue about whether the cement is going to spill out of this box of the vertebral body or not. So just recently saw somebody doing it, so I thought it's a good practice. And the only problem with that, that lot of this dye is still there. I mean, though I aspirate it out as much as possible once I'm done with my checking of the spillage, but still some dye is left behind. And when we are putting the cement in, some of this dye is the first to go out, and it gives it's unclear to us whether it's the dye which is coming out or whether it's the cement which is coming out, and should we stop there? So that's one problem which I saw with, but I do still tend to inject the dye to ensure that there is no major leakage from the vertebral body happening. Right. Any of you are doing this thing?
That also decides, like in my practice, to use a 2 needle or just 1 needle for an individual vertebra. So if
that also decides what?
The use of the number of the needles. So what I do is I usually insert 1 needle, use a dye in order to see the spread of the dye inside. So if there is a good spread in the vertebral body, only 1 needle is pretty good enough. And if
yes, that's a good thing.
Yeah, so that is one of the thing which also helps you to just take.
Otherwise, you put another needle.
Bipedicular or unipedicular.
Yep.
Yeah.
Yep. Okay, so I think this is a simpler case. We'll have one more case discussion. Let's talk about this one. So another lady, 73-year-old, history of fall in bathroom. When she came to us, she was 3 weeks status post fall. Her pain was severe. She was being seen by a local physician, not orthopedic surgeon. The day when she came to us, she had bilateral leg numbness along with the pain in the thoracolumbar area. As of now, neurologically, she was normal. And she came with a DEXA report, which was showing minus 2.9 of the value. And this was the X-ray. I mean, you can see that her bone shadow is almost similar to her soft tissue shadow. So, Shiblee, what's your thought about it? She has bilateral leg numbness,
So there's severe osteoporosis. Need to know how this X-ray was done. Okay. Many of the time,
This is fine X-ray because she was not able to sit,
Okay. So here, if the patient has bilateral leg numbness, not able to stand and walk individually and need support, I would like to go for an early scan in the form of MRI in order to see what and where things are happening inside and how much is the neural compression. My major concern is the neural compression because many of the time patient has dynamic compression happening inside because of the porosis.
Yes. So even in this static MRI, we can see there is a significant amount of retropulsion of the, especially the posterior superior corner of the vertebral body, and quite a bit of spinal cord compression as well. So I think we are looking at surgical option here. Deepak, correct?
Yes.
And in your morphological classification, where will this fracture fall? Grade 4 or 5?
This is 5, I think. 4 or 5 somewhere. 4 or 5.
Yeah.
4 is definitely yes. If there is a posterior element involvement, then distraction 5. 5 भी बोलेंगे.
Looks like the posterior element looks okay. So I think grade 4. So on axial cut, there is significant narrowing of the spinal canal, and because of the patient 3 weeks history and neurological symptoms, we decided to go ahead with the surgery. Now in surgery, like anterior reconstruction and all those things are there, but in terms of the fixation, would you, because you'll be using the cemented screw, would you restrict your levels because you are using the cemented screw, or it doesn't matter? You'll still go for maybe 3 level up or 3 level down, or because you are using cemented screw, you can restrict yourself to 2 level or 1 level only.
In my when it's a junctional area and so much of reconstruction, 2 level above, 2 level below with cemented screw.
Okay. ठीक है. Rakesh, do you use these cemented or fenestrated screws?
Yes, I usually use fenestrated screws, and even in this case, I will go to 2 level above, 2 level below, and anteriorly, I would just circumferentially as much as I can 180-degree decompress the cord, and I don't think anteriorly I will put anything considering the overall age and comorbidity. 73-year-old lady, she's not going to have much demands, not going to put a lot of weight, and she just needs to be mobile. So I think good purchase of screws and tight follow-up. I would.
So this is what was done actually by us. The screw hold was not so good, and we started doing the decompression. Just to remove that posterior corner of the vertebral body. Lots of vertebral chunks came out. So it was a full void over there. So if we didn't feel that, I mean, it was definitely not fillable by the cement because it was not a box kind of thing anymore. It was just shattered pieces of bone, and so there was a big void. So we thought that it's prudent to kind of give it some sort of anterior support. Luckily, the upper end plate of the tibial vertebra was that upper end plate with little bit of upper cancellous part of the bone was still intact. So we were able to rest our cage on the upper end plate of the L1 to the upper end plate of the T12. By going through the body. And again, because the hold was not so good, so we thought that we'll go 3 level above, 3 level below. And the transfer connector was applied for added stability. Uh, Deepak, what do you think about this? I'm worried about that the upper and the lower screws are they might loosen up because, this is osteoporotic bone and they are notorious for not healing. Ultimately any implant is, the success of the implant will be decided based on whether the implanted levels are fused or not. So number one, the fusion will be an issue, and number two, if the fusion, if the fusion takes place, the adjacent segments are at stress. What do you think, Deepak, here?
Whenever there is an osteoporosis, even in degenerative normal listhesis, I have seen in my patients, I see that the screws will start loosening up above or in the uppermost part, and that causes trouble. So I will be little afraid if in present scenario, if I have to do this construct, I'll still cement the upper and the lowermost screws. That is my tendency nowadays.
Shiblee, what would you have done differently?
So two things. One, here in such osteoporotic patient, I completely rely on the C-arm. So I keep the C-arm in my lateral view. Or it just once you get one time to insert a screw here. If you need to change the direction, the hole would be gone. I usually prefer dual thread, but it's just one chance. And I do an untapped insertion of the screw and try to get the bicortical purchase. So this is one regarding the insertion of the screws, dual dual thread, bicortical, and just one untapped uh, thing. Second, insertion of the rod. The majority of time, what mistake we do is we are very keen of giving shape to the rods. Okay, in osteoporotic patients, they usually have a tendency of falling down, the kyphotic posture. So when you give a good S-shaped curve or you try to get the screws to the rod, they usually tend to fall because the whole construct is gonna come out. So just try to insert the rod or give a shape of the rod as it is gonna go in and fit into the tulips. Don't give a normal anatomy to the rod. Give a shape to the rod as it is gonna fit inside. So that two precaution which I usually take in order to prevent the further loosening in osteoporotic patients.
Yep. Rakesh, what are the other things could have been done in this case to prevent, all these problems, other than the screws being cemented? Or if this case comes to you today and you have to do similar sort of construct, what are the other additional things?
With this construct, I am like the case when we saw Dr. Deepak sir showed us one of the case with that much of a stiffer construct, like we already discussed. I'm just worried even after it fuses, the upper is very soft structure and the lower is going to be a stiff structure. So the landing at the interface is going to might be a problem in the future, and hence my reasoning why I said for two levels with the cemented screws. And maybe also consider soft landing by adding just putting cement at the level above the construct. That might also be
Yep.
possibly one of the thing we can consider. And again, putting for the proximal junction, if you are really worried intraoperative how the hold was, then can also add wires at the top end so as to make the landing a bit soft and slightly just bit slightly at the top, contour the rod into kyphosis, but maybe not at this level. I'm sorry, not at this level.
Off late, I've
Other
been wires quite a bit, but the issue with them, they come in steel only. And so post-op MRI, for any reason it is required to be done, gets a little difficult.
Yeah.
Sorry, I interrupted you. Please proceed. Please continue.
Other thing, then yes, also maybe a bit the follow-up part after the surgery. We want to be really making sure that the patient does turn up and be compliant with whatever osteoporosis management we have advised. And nothing else really what I can think of. That's all. I mean, we had to do the surgery. The patient did not have an option. There was no option to leave her alone. We needed to put decompress and put the metal work. And if you put the metal work, this is it is going to come with the risk. So it's really the conversation we have with the patient and explain them. If the implant fails tomorrow, that's just the luck, and that there was no choice of not doing the surgery if you want to be mobile.
Yeah, one other thing which I have seen that some people, what they do across the lesion, they will put 4-rod construct. So they will put side connectors from this index rod, and they will connect, like 2 rods on each side, 1 rod on each side, connected by end side to side connector, like crossing the lesion. So their idea is that like they are giving extra rigidity to the
Construct.
to the problematic area, and like then they will probably skip doing all this anterior reconstruction. So their idea is that that we are avoiding doing any major anterior reconstruction, but at the same time we are giving additional posterior stability so that the healing can take place on the front. So that's another thing. And I think some people, you might have seen that they are putting just the bone graft also rather than cement in these, like through the same needle, they will shove in the bone graft which has come out from there. Okay. Anything else, Deepak, I'm missing here?
I think no, because in such patients you can only try to do the best and then leave things for the luck also.
Yeah, we had no choice in this patient. Needed.
I think with this we'll be finishing today's session. It was great having all three of you here, and
Thank you so much.
we will, opinion for these cases as well as your lectures. And the primary aim of these series is to kind of create a repository so that these are available on the Ortho TVs and YouTube. So these residents and fellows. So this was the 10th in the series. So whenever they want to kind of have a look at a topic, they can just revisit these lectures and can get. I think if somebody can attend these lectures, they get enough knowledge about so to appear for the exam. So that was the aim of having these lecture series. So well, thank you again, Deepak, Shiblee, and Rakesh.
Thank you, sir. Thank you, everyone.
TV, and thank you for your sponsorship. Good night. Good night, everyone.
Good night. Good night.
Thank you.
Thank you.
Poonam, we can log out, please.